patients who got radiation, they need very close monitoring, early mammography, rather than waiting to the usual time, much closer observation so we can pick up these things early and prevent them from having something terrible happen. Finally, I want to mention something about the adolescent young adult age range. This is an area I'm particularly interested in. Now, David is getting very involved. Actually, between he and I, we probably have more people at a national level interested in a pediatric institution, interestingly, interested about this issue than anywhere. I'm on the Young Adult Alliance Task Force for the Lance Armstrong Foundation on this, and David is leading the COG effort in this area. And the reason we're so focused on this is if you look at the adolescent young adult age range, it has the lowest improvement of outcome over the past 30 years of any age range for cancer. Actually, if you play this all the way out to 80, 90-year-olds, there is this dramatic trough in the middle here of lack of improvement in outcome of young adults with cancer over the past 30, 40 years in this country. It's not that they do necessarily the worst. They actually don't do too badly overall, but they have not improved their survival very much since 1975, 1980. And in fact, if you look within a couple of these age ranges, they actually have gotten a little bit worse. So this is an area of great focus, and I can tell you that I just came back from a meeting that I co-chaired in Bethesda, where we're developing national standards like you saw for the pediatric cancer programs. We're developing national standards for treatment centers for adolescent and young adults with cancer that not only take into account all the medical stuff, but also deal with the unique psychosocial, environmental, other aspects of being an adolescent or young adult with cancer, which frankly are some of the reasons why outcome is not better, because of all these other factors that impact adolescents and young adults who develop cancer that interfere with their ability to get proper treatment and follow-up. So this is a major area you're going to hear a lot of. Now, for those of you who are not aware, and I mentioned this just in terms of looking at one of the factors that are important in our advances, the Children's Oncology Group, which is now the single national group studying clinical trials in childhood cancer, represents virtually every single pediatric cancer treatment program in the United States, about 240 or so, plus all the treatment centers in Canada, and a few in Australia and Switzerland and a couple other places. Here we are in LA. There's a bunch in LA, as you know. This shows you the percentage of patients in the United States who develop cancer who go on clinical trials, national clinical trials. You can see every child under the age of 4, essentially with cancer, goes on a clinical trial. They go to pediatric centers. Almost all children up to the age 14 go on clinical trials. But then you see this dramatic drop-off. Remember I mentioned that the fewest number? These patients are being treated in private hematologist and oncologist offices, adult hematologist and oncologist office. They're not going to the major centers because virtually all the pediatric cancer care is done at major centers. Anybody have an idea what percentage of adults with cancer go on national clinical trials? Anybody want to take a guess in this country? This country? 3%. I think it may be 4 now. It went up slightly. Almost the vast majority of adults with cancer in this country are treated in private offices by private hematologist oncologists using treatments that have been published in the literature that they've heard about that they think are the best treatment for that particular cancer. Now, you know, the problem is that for a lot of these cancers, we don't have the best treatment yet. And so the best treatment is going to be in the context of a treatment protocol that is asking the question, can we do better? Okay, it doesn't always turn out we do better, but many of the times we do better with those protocols. The other thing that treatment protocols provide is they provide a very clear framework. Some people talk it as cookbooky, but really there's tremendous advantage to this. They provide a very clear framework for how you manage the treatment. How much of the drug you give, when you modify it, when you don't, how much you modify it. It's a standard approach. And what people sometimes forget is that what's published in the literature as a best treatment from a treatment protocol is based on using it that way. Not using it ad hoc, but using it according to the specific guidelines in that protocol. So providing that framework for the treatment is as important as telling you exactly what drugs to use.